Hello and welcome to Zoom session number 5 for our 125 Hearing Disorders course, July the 1st, 2019. Today what we plan to do is to finish off Unit 2, Inner Ear Disorders. Last week we covered presbycusis, and we looked at 4 types of presbycusis, Schuchnigt's classification. Take a look at your notes, and then we got into noise-induced hearing loss, and all the while describing these disorders, presbycusis and noise-induced hearing loss, which are, of course, the number 1 and number 2 causes of sensory neural hearing loss. And while covering those 2 types, we paid a lot of attention to the audiograms. We talked about the hearing test results in terms of listening to the tones under headphones, and then of course speech audiometry, and then a little bit of tympanometry. Very helpful to keep these things in mind. Let's share screen here and see where we've left off. So why don't we go here, share screen, and take a look at the PowerPoint first. Why not? It's more fun. Okay, so look at the type of hearing loss with typical presbycusis. Note that the hearing loss is the same by bone conduction. This is the greater than signs. Bone and air conduction. Headphones shows a sloping high frequency hearing loss. Bone conduction shows the very same thing, meaning that when you avoided the outer and middle ears by putting the little box on the mastoid bone behind your ear, the hearing was no better. Okay, so therefore the loss is inside, of course, the inner ear or cochlea. Looking at speech discrimination. Speech discrimination, I'm going to skip this slide here. You know why? Because this is all in sound pressure level, which is kind of like we don't do hearing tests in sound pressure level. So let's forget that. Here you're looking at dBHL, hearing level, on the audiogram. And you're noticing for someone who has normal hearing, number 1, the way they heard spondee words, the 2-syllable words that were getting softer, 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 softer. And you pretend that this person has a 10 dB hearing threshold. You can hear all sounds down 20 dB, 15, down to 10, but can't hear 0 or 5. Okay, and his pure tone average, let's say, his hearing levels at 500, 1000, and 2000 hertz. 500, 1000, 2000 hertz. What would be the pure tone average here? Around 40, because 30 plus 40 plus 50, add them up, divide by 3, you get something like that. So this person would normally hear spondee words as well, down to about 40 decibels in speech. That's what we mean by speech reception threshold. The softest he could hear speech should agree with the pure tone average. This is always a cardinal rule in hearing testing. The hearing thresholds, the average hearing levels of these 3 frequencies, Parent-Teachers Association, PTA, pure tone average. If that's going to be X, in this case 40-ish, the softest that he can hear speech should be around 40. So look at number 1, this person's pure tone average may be 10. So he should hear the words down to about 10. This is the level that the words were presented, and this is the percent correct he got. And when you were at 5 dB, he got none right. And when you were at 10 dB, he got most of them right. And when you're at 15 dB, he got them all right. So that's the softest level he could just barely hear. Maybe for the person here, okay, this person's hearing levels are pure tone averages around 40. I don't know. What about here? Number 3. Okay, the softest he could hear words would be around 40-ish. Now these, if you look at number 2 here, this is single syllable words. So for someone with normal hearing, okay, single syllable words, if I'm reading them at 10 dB, he's going to get none. But if I read them at, or at 5 dB, he's going to get none. If I read them at 10 dB, he's going to get only a few. See? Single syllable words. 15 dB, he's going to get about 25% correct. 20 dB, he's going to get about, So I'm correct. This 80 doesn't belong here. This 20 should be 40 here. It should be 60, 80, 100. So that's wrong. But anyway, see how single syllable words are harder. Look at here at 10, he gets most of the spondees right. At 15, he gets all of the two-syllable spondees. What are spondees? Those two-syllable words with even emphasis on both syllables. Hot dog, cowboy, sidewalk. Those are what's used to test the softest level you can hear speech. Single-syllable words are presented above your hearing levels at a most comfortable loudness level, and you count the percent that the person gets correct, and you're not making them softer. Okay, that would be what number 2 is showing here for the same normal hearing person. Okay, if you're looking at number 3, monosyllabic words and sensory neural loss, see how he never gets 100%? Okay, see, it needs him louder to hear because he's got a hearing loss, but he never really gets 100%. You see that? That's because he's got inner ear hair cell damage. Okay, and that's what's unique about sensory neural loss as opposed to conductive hearing loss. Because conductive hearing loss, remember, is like a plug in the ear. Present the words loud enough to get through the plug, and the guy's going to hear them all. Okay, but sensory neural, there's nothing blocking the passage of sound getting to the ear. Nothing. It's the hair cells themselves that are damaged. And that is why one of the keynote features of sensory neural loss is that word recognition with monosyllabic words, single syllable words. Those words never really get to be 100%. Okay? Because the hair cells are damaged there. Now, here you're looking at types of tympanograms. Remember from last week. Type A is a normal tympanogram, and sensory neural loss has nothing wrong with the middle ear. So they will have normal tympanograms just like a normal hearing person will. Okay? Acoustic reflexes are the little tiny muscles that pull when a loud sound is put in the ear, and that's also done by way of tympanometry. You can learn more about that in your audiometry class, but acoustic reflexes, if a person has a conductive loss, you're looking at the straight line here. With any degree of conductive loss, you've got a high absence of acoustic reflexes. Look at the axes, okay? With cochlear sensory neural loss, if you got 20 dB loss, you should still have acoustic reflexes. You got a 30 dB loss, you should still have acoustic reflexes. Percent of absent, look at the vertical axis. It's only when the loss gets to be beyond about 60, now you start losing acoustic reflexes, and that's because outer hair cell pathology causes a mild to moderate loss. Look what I'm circling here. Causes a 0 to 20 to 40 to 60 dB loss. The hearing loss that's shown here, mild to moderate sensory as opposed to neural, outer hair cell pathology as opposed to inner. Okay, and when you get beyond 60, now you've got inner hair cell pathology. And remark and know this well. Okay, I'll stop sharing. Acoustic reflexes do not, repeat, not involve outer hair cells. What is involved with acoustic reflexes? Inner hair cells. What is the acoustic reflex arc? Remember from anatomy? Outer ear, middle ear, inner ear. Hold on, what part of the inner ear? Inner hair cells. 8th nerve going to the brainstem. And that's the afferent root. Now efferent back, you're going from the brainstem down the 7th cranial nerve and the 5th cranial nerve. And the 7th cranial nerve going back to the ear ends at the stapedius muscle, pulling the stapedius muscle. And the 5th cranial nerve going back to the ear terminates on the tensor tympani muscle. So those two nerves are part of the acoustic reflex arc, the loop. So when inner hair cells are involved, you may have an interruption and a disruption in the acoustic reflex arc. And that is why when the loss gets to be greater than about 60, because outer hair cells help the inner hair cells pick up sounds below 60, okay, or 50, something like that. When you've got a bigger sensory neural loss, you must, M-U-S-T, you have to have inner hair cell damage as well. Outers cause about a 50 dB loss. If you've got an 80 decibel loss, you know that inner hair cells have to be involved. Outers tend to die before inners. So with an 80 decibel sensory neural loss, you'll have a high likelihood of absent acoustic reflexes. Why? Because the inner hair cells are necessarily involved. Something else too, with sensory neural loss that's severe, around 80 decibels or something like that, their word recognition is also going to be poor. Why? Because now not only outer hair cells are involved, but also inner hair cells. And when inner hair cells are involved, you're getting a garbled speech message being sent to the brain, because inners are afferent. They send info to the brain. Outers are efferent. They take info from the brain. And remember, they are the muscles of the cochlea. They amplify and they sharpen the peak of the traveling waves. But they don't send sound to the brain. The inners do. Just remember, the inners cannot pick up sounds below 50 or 60. That's why the outer hair cells are involved, to help them do that. Okay, and that's the way the general physiology of the cochlea works. All right, sharing screen. Let's go back to our PowerPoint here. Okay, and then cochlear nerve, 8th cranial nerve damage. That's going to be what we'll look at next week. Retrocochlear pathology, 8th nerve pathology. Look at when you've got any hearing loss due to that pathology, you have a high likelihood of absent acoustic reflexes. But we'll look more at that next week. Okay, carry on here. Recall, acoustic reflexes are not to protect against noise-induced hearing loss. That's one of the fallacies we are commonly led to believe. Acoustic reflexes occur especially while we talk. That's why we have them. Because remember, we hear ourselves through air conduction, but we also hear ourselves through bone conduction. Okay? How do we hear others? Only by air conduction. Remember a recording of your voice, how you sound when you're listening to a recording of your voice. You're the only one that doesn't like it. Everyone else says it sounds just like you. How come? Because now for the first time you're hearing yourselves as others hear you, by air conduction only, not by bone. Okay, so you hear yourselves or others by air conduction at around 65 dB SPL and somewhere between 50 and 60 dB HL. We hear ourselves talking louder than that, because we hear ourselves through air conduction, but also through bone. So we hear ourselves around 80 to 90 decibels HL. And that's why we have acoustic reflexes, because 80 to 90 is enough to cause those muscles to contract. So your acoustic reflexes occur to help dull and weaken the loudness of your own voice while you talk. Weird, huh? Share screen. Back to here. Acoustic reflexes tend to be strongest for low frequencies because our voices are loudest for the vowels and the low frequencies. Here's acoustic reflexes. When 80 decibels comes in, 85, 90, 95, you can see acoustic reflexes occurring. What these little V's or U-shaped things are, actually, they are reductions in the peak of the tympanogram. If I stop sharing for a second, it's going to be the peak of the type A tympanogram in someone who has sensory neural loss. When the acoustic reflexes occur, that peak goes down a little bit. How come? Because the middle ear becomes more stiff. Remember the axes of a tympanogram? Let's make sure we've got that. Nothing wrong with making sure we have some things in order here. Okay, look at the axes. Air pressure, compliance. Remember, compliance is the opposite of stiffness. So the more compliance, look at the cursor here, the higher the compliance, the less stiff. So when your acoustic reflexes kick in, you're making your ear more stiff. So more of the sound's going to bounce off the ear. So your type A tympanogram is going to get lower. for a split second during the time that the acoustic reflex pulls and kicks in. Your type A will go down. Remember, acoustic reflexes are not using air pressure to make the tympanogram. They're using a loud sound and finding out what happens to the compliance. Okay? All right, so a type A tympanogram, meaning normal air pressure, even Steven on both sides of the drum. You're putting a loud sound in the ear and you're trying to figure out, did the little muscles contract? And if the little muscles contract, they made that stiff middle ear system even more stiff. And so the whole pup tent will go down for a split second, meaning it'll be more stiff during the time of the acoustic reflexes. So this is the reduction of the peak of that tympanogram. Notice it always gets reduced with the loud sounds being put in the ear. This is showing you the height of the tympanogram, and this is showing you the reduction in the height of the tympanogram due to these acoustic reflexes. Enough on that. Enough on that. Don't worry about it. Let's just kind of, yeah, well, it never hurts. Acoustic reflexes are always reported in sensation level. Remember that too. Okay? You may have acoustic reflexes kicking in at, let's say, 85, because this guy had an acoustic reflex. But if his hearing loss was 50, what was his sensation level? 35. 85 HL, dBHL was the intensity of the sound put in his ear. But if he has a 50 decibel hearing loss at that frequency of the tone, then his floor of hearing is 50, the tone was put in at 85, his sensation level for that acoustic reflex was 35. If I have normal hearing and can hear down to 0, and I have an acoustic reflex at 85 dBHL, my sensation level is going to be 85 dB SL because my floor of hearing is 0 and the tone came in at 85. So always remember that. Acoustic reflexes are always reported in sensation level. They are tested in dBHL because the instrumentation is calibrated for dBHL, and they're typically found between 80 to 100 dBHL. They're reported in dB sensation level relative to one's own hearing thresholds. Mild sensory neural loss may have acoustic reflexes at a similar dBHL to someone with normal hearing. But of course, the sensation levels will be very different. And that's what the example here is given. Have a read. Normal hearing and a flat sensory neural loss may have acoustic reflexes, both of them at 100 dB. But the normal hearing loss has acoustic reflexes at 100 dB SL, sensation level. The sensory neural loss may have acoustic reflexes at a reduced sensation level because his or her floor of hearing is 50. So if the acoustic reflexes kick in at 100, the difference is 50. Acoustic reflexes and speech discrimination. Acoustic reflexes, remember, always deal with inner hair cells. Remember the acoustic reflex arc. If you're looking at otoacoustic emissions, which we'll finish today with, they deal with the outer hair cells. So the outer hair cells are not involved with the acoustic reflex arc. And look what it says on italics here. You may have two people here with the same moderate sensory neural loss, much as is being shown here. Okay? Maybe two people have this kind of hearing loss. However, one person might have pretty good speech recognition at a most comfortable level with those monosyllabic words. And another person may have quite poor speech recognition, even though he or she has that same mild loss. Okay? They may have very different speech discrimination or word recognition. The one with the good speech discrimination probably has acoustic reflexes, albeit at reduced sensation levels. The one with the poor speech discrimination may have absent acoustic reflexes because maybe that poor person has damage to both sets of hair cells, and that's what's causing his or her hearing loss. Whereas the person with the good speech recognition, his or her hearing loss may be confined only to damage to the the outer hair cells, and yet the inners are still fine. So have a read of this slide. Very important. Acoustic reflexes involve inner hair cells, a very unique test underused today. Two people with same sensory neural loss, one might have good speech discrimination, the other one with worse. Chances are the good speech discrimination person has acoustic reflexes at reduced sensation levels, whereas the person with the poor speech recognition or discrimination may have damage to both sets of hearing loss and that hair cells, and that's what's giving rise to his or her hearing loss. Now, we can't see inside the cochlea. It's illegal to do that. Okay, you can't cut someone open and check, can't get in there, but acoustic reflex testing, that's why it's kind of a test to use in conjunction with speech discrimination. Okay, if someone has abnormally poor speech discrimination and only has a mild to moderate sensory neural loss, it may behoove of us to check the acoustic reflexes if they occur. Okay, outer hair cell damage, normal. Outer hair cell damage, all right. If the loss was mostly to the inner hair cells, it would result more in neural hearing loss. Noise-induced loss, there's the trademark of noise-induced loss. Remember from last week, the unique shape of the audiogram, mainly caused due to the resonance properties of the outer ear and canal. And remember the half-octave shift. Okay, the basilar membrane displacement tends to be greatest at around a half an octave higher than the frequency of the loud sound. So if you have a broadband loud sound, lows, mids, and highs like factory noise, chainsaws, God knows what, if that's being pushed into the ear, the outer ear canal naturally resonates with these frequencies, which is going to create an artificial lift in loudness at these frequencies. And this next slide is saying actually inside the cochlea, the basilar membrane, the peak of the wave tends to be greatest around a half an octave higher than the frequency of the stimulus. And so if the sound tends to be pushed through this type of resonance, the damage is going to occur a half an octave higher. So slide this about a half an octave higher and turn it upside down, and what do you got? Noise-induced loss. That's why 8,000 hertz hearing levels get better than 4,000, and it's because this drops over there. Okay, so take this, shift it to the right a half an octave, flip it upside down, and you get that. The shape of noise-induced loss. This is just showing you hair cells that are damaged mostly at one particular frequency region. Okay, 4,000 hertz region. Yeah, right there. So the hair cells are damaged. Summary of studies showing noise-induced loss. 85 dBA. Last week we talked about why the A on the end. Suffice to say, it's dB/SPL, but basically with the human hearing across the frequencies taken into account. With 85, 8 hours is allowed. 95, okay. Summary of 5 studies on predicted permanent threshold shift. So if a person's listening to 85 dB sounds, okay, this is what they're going to have in terms of threshold shifts. 90 dB is going to have more damage. 95 is going to have more damage. Note in all 5 studies, as the noise is increased by 5 dB, the threshold shift or the noise-induced hearing loss is more pronounced. And here you're looking at the interaction between the loudness of the tone and the time you're exposed to it. You're exposed to 8 hours a day for 90 dB, and as the time, if you're exposed to 92, less time is allowed. When you get to 95, the time is cut in half. Now it's 4 hours. When you get to 100, the time's cut in half again to 2 hours. When you get to 105, the time's cut in half again to 1 hour. Essentially, as the intensity goes up by 5 dB, the allowed time of exposure gets cut in half. Some people say 8 hours for 85 dB. Some people say 8 hours at 90 dB. Just depends on what state you're in, what jurisdiction. Okay, but this is talking to you about the permissible noise exposures and that what causes noise-induced hearing loss. Here you're looking at people who've been exposed to noise over a longer and longer time. And so you can see this here, exposure, and then here even more length of time, and you can see how the noise-induced hearing loss got worse and worse. Generally, the shape of noise-induced hearing loss is what we need to know in this particular course. And here you can see someone who died, who had noise-induced hearing loss, and you can see the hair cell count. Living, inner hair cells, the top, outer hair cells here, and you can show that they're all dead near the basal end of the cochlea. And here you're showing a right-handed hunter. Now remember, a right-handed hunter is going to have the left ear more exposed to loud sounds because the rifle barrel is going to be closest to the left ear. And you can see that the left ear has more hair cell damage than the right ear does. Now we can leave noise-induced loss, but just a sec here, make sure we've got, let's take a peek at our notes here. We've got noise-induced loss. We did this last week, okay? If a case history, let me make this a little bit larger. If a case history reveals noise exposure, always test at mid-frequencies next to 4,000 hertz. The SRTs are going to be quite normal because the guy has good hearing at the speech frequency at the 5, 1, and 2. Let's look at that. What's the pure tone average here? Around 15. Look where I'm circling. So the softest level that he can hear, those two-syllable spondy words, is going to be, has to agree with that average. Okay, that's what I mean by it. Speech discrimination with single-syllable words is going to be excellent because the guy hears pretty good, except at 4,000 hertz. It'll be pretty good. They'll be troubled by background noise. Tympanometry will show normal type A tympanograms. Acoustic reflexes will be present, albeit at reduced sensation levels. And then this thing about the hunters. And the degree of noise-induced hearing loss can vary from person to person in the same place because some people have tender ears, some people have tough ears, different shaped canals, etc., etc. So it doesn't mean that everybody's going to have exactly the same noise-induced hearing loss shape. They will differ to some degree because people are different. Now let's look in our notes at sudden idiopathic deafness, SID. Idiopathic means we don't know the cause. It'll hit young adults, can hit adults in midlife, often affects one ear with almost complete deafness. Onset of hearing loss will occur in 3 days or less. Steroids are often prescribed to offset the effects, but not always successful. Sudden idiopathic deafness accounts for about 1% of sensory neural loss. Only 10% of cases receive a formal diagnosis, and this is why it's called idiopathic. Idiot. We don't know the cause. We just don't know. Some people think it's a spasm of the internal auditory artery, something like a lack of blood supply for some reason to the ear. Remember, the stria vascularis is the blood supply to the cochlea. So maybe the artery that supplies the blood supply to the stria vascularis suddenly seizes up. Who knows? It says here the internal auditory artery supplies blood to the stria vascularis. A spasm of the artery closes off the blood supply. Some think it's an immune system, like an AIDS autoimmune disorder, okay, of the inner ear. Anticochlear antibodies. autoimmune system? We just don't know. That's why they call it idiopathic. I wonder if I have a picture of anything to do with it. Let's just see if I do or not. I'm not sure. Just checking here to see. Maybe, maybe not. No. But nonetheless, let's go to our notes and make sure you realize it's not common. It's usually one ear, and it's almost total deafness in that ear. And what's the only thing that can be done about it? Get to an ENT quickly. Steroids is usually the only option. And many times, if you've waited for 24 to 48 hours after the person suddenly lost his hearing, it's too late. There's a lot of medical doctors, general family practitioners who don't take it seriously. They'll just say, you got an ear infection. Oh no, that would cause a conductive hearing loss. So if the person has a sensory neural hearing loss that suddenly occurred overnight in one ear, get to the doctor quickly. Make sure it isn't an infection. A good hearing instrument specialist can tell if it's a conductive loss or not. If it's sensory neural, send to an ENT quickly. The ENT will appreciate your efforts, will give the patient antibiotics, and that may bring the hearing back some. Okay, so now you've got 3 types, and remember from last week too, we had ototoxicity. Remember that? We talked about that too. Let's see how many types of sensory neural loss we've covered. Way up here. You had your we talked about prenatal, perinatal, postnatal. We broke it down that way. We said you could have all these different causes. We talked about those before. But then we break it down into what's most common. Ototoxicity, due to antibiotics that end in mycin, aminoglycosides. Presbycusis, noise-induced loss, sudden idiopathic deafness, and now that brings us to our next type, Meniere's disease. Meniere's disease, sudden, paroxysmal means episodic. Okay, symptoms of 3 things, the classic Meniere's disease: vertigo, sensory neural loss, and tinnitus. Now, by vertigo, I don't mean just kind of dizzy. You're going around and around and you're throwing up. It's awful. Paroxysmal means it hits you in an episode. Here it comes, and now I'm going to get it. It's like a person with seizures has an aura, knows that he or she is going to have a seizure, can feel it come on. People with Meniere's disease have the same thing. They can tell they're going to have an attack. That's what they mean by episodic, paroxysmal. And it's 3 things that happen together: vertigo, sensory neural loss, and tinnitus. It's usually unilateral, once in a while bilateral, but usually one ear. Client reports a full feeling in one ear, then a low frequency roaring tinnitus, not a high frequency ring. A roaring tinnitus, hearing loss, and rotary vertigo. Very handicapping. Terrible. You wouldn't want to wish this on your worst enemy. Caused by endolymphatic eye drops. Too much endolymph fluid in the scala media. Put a star by that. Not paralymph. Too much endolymph fluid surrounding the hair cells in the scala media. Remember, the scala media is the membranous labyrinth, bordered by the basilar membrane on the bottom and Reissner's membrane on the top. It's the triangular shape in the cochlea. Too much fluid in there. Now, you can have simply endolymphatic hydrops, which means too much fluid. And so not all Meniere's is the same. In other words, all Meniere's is endolymphatic hydrops, too much fluid. But not all endolymphatic hydrops gives the 3 classic symptoms of Meniere's. Meniere's is the 3 classic symptoms shown right here. Many times, people with too much fluid in the scala media won't have classic Meniere's. They'll have 2 of the 3 symptoms, not all 3. So endolymphatic hydrops is like a broader term And then Meniere's disease is kind of like a subset of endolymphatic hydrops. All Meniere's is endolymphatic hydrops, but not all endolymphatic hydrops gives the 3 classic symptoms of Meniere's. Might give 2 of the 3. Okay, so here we go. Let's look at a picture of it. Look at a picture of Meniere's. Move on down here. Classic Meniere's disease. Now, what we've done, I've taken the scala media and laid it across the audiogram. Okay, and at the apex of the cochlea, which is the narrowest, remember the basilar membrane is the widest. Look at your early PowerPoints in this slides in this particular unit. Okay, and you've got the pictures there clearly laid out. At the apex of the cochlea, here, apex of the cochlea, basilar membrane is the widest. At the base of the cochlea, basilar membrane is the narrowest. All right, now back to where we were. Boom, boom, boom. See all the ground we cover? All right, so the scala media, call that the basilar membrane, whatever you want to call it, the hair cell region. You'll have inner hair cells, follow my cursor, following like a line all the way here. And then you'll have 3 rows of outer hair cells here, 4 rows of outer hair cells here, 5 rows of outer hair cells here. The right ear here is normal, and the Meniere's is attacking this person's left ear. And look where the hearing loss is most in this case. Contrary to hearing loss in the treble regions, it's the opposite. It's worse for the bass. And Meniere's is one of the few types of hearing losses that actually causes this. Now, genetic hearing loss, this could be genetic too. But if the person is, because genetic can have any shape of hearing loss. But remember with Meniere's disease, if the person has been reporting symptoms and you've taken a case history of the person, and the person has reported these symptoms, and you can find the hearing loss like this, notice the bone conduction agreeing with the air conduction, so the loss is sensory neural, and the right ear bone conduction agreeing with the air conduction of the right ear. So the right ear is normal. The left ear has a low frequency sensory neural loss. Why low? Because with too much fluid in the scala media, what takes place at the base of the cochlea? It's less mass and more stiff. And as you get toward the apex of the cochlea, you've got greater mass and the walls have less stiffness. And low frequencies, or I should say, so if you pump excess fluid into the scala media, if you pump and fill this thing up with excess fluid, where are the walls going to give? The walls are going to give where they are least stiff and where there's a bigger area of the wall to be bent. So at the apex of the cochlea, Reissner's membrane is longest and the basilar membrane is longest. Okay, here you go. And that's why excess fluid is going to bulge the walls more at the apex of the cochlea than at the base of the cochlea. So now let's look at our notes, our PowerPoint, and go back down to see it. See, what you're learning here is not only that Meniere's disease has a low frequency hearing loss and is characterized by that, but you're learning why. Excess fluid in the scala media is going to bulge the walls where they have most mass and least stiffness. There's more wall to bulge here at the apex. These walls are going to give. Okay? Remember, the scala media is most stiff and has least mass at the base of the cochlea. It's less stiff and has more mass at the apex. Excess fluid is going to bulge that. The flaccid scala media at the apex, most affected by excess endolymphatic pressure. Here again, because of the mass stiffness properties of the basilar membrane, more mass and less stiffness at the narrow apex of the cochlea, more stiff with less mass at the wide base of the cochlea. That is why you're going to have a bulging of the walls mostly taking place here. Again, a cross-section of the cochlea. Notice that the Reissner's membrane and basilar membrane are wider. There's more mass there. Putting more fluid pressure is going to bulge these walls here more than it will here. The whole middle scala media is stiffer there. Now, before we close this section, or we get to the near the end of it, let's look at our notes under Meniere's disease. The glycerol test is used to diagnose Meniere's disease. Glycerol is a diuretic. It makes people pee, okay? So if you're drinking glycerol that the doctor gives you as a test for Meniere's disease, and after you've taken the diuretic and you've peed and your Meniere's disease is a little bit less, the doctor's going to confirm that, yeah, you know what? When I gave you the diuretic, you had less endolymphatic hydrops, less fluid buildup of pressure. So if a diuretic works, then that's a positive, meaning a bad indication. It's a positive sign of having Meniere's disease. The assumption is that increased urinary output will reduce endolymphatic hydrops. So just realize that one of the tests given to diagnose Meniere's, DX means to diagnose, is a glycerol test, a type of diuretic. The audiogram for Meniere's, flat or rising, moderate in degree. There you go, you have your reasons now. And tympanometry, type A tympanograms, maybe a slightly reduced static compliance. In English, a slightly reduced height of the type A due to excessive fluid in the cochlea. Your whole middle ear system might be a little stiffer because your whole cochlea is just filled with excess fluid, and the middle ear system, it gets even stiffer because of that excess fluid built up in the cochlea. But enough on that. You'll have acoustic reflexes, albeit at reduced sensation levels. And one more thing to show about Meniere's disease is that it doesn't always immediately hit like this. Okay, it'll leave you with a bit of low frequency loss after one attack, and after another attack it'll leave you with a little bit more low frequency loss, and after another attack you'll be left with a little bit more low frequency loss, and so on. And eventually this may even flatten out a little bit toward the highs after repeated bouts of attacks. Generally, Meniere's has about a 5-year lifespan. The person will be subject to attacks of Meniere's disease beginning at some particular time, more in one ear than the other ear, and the Meniere's disease you have to let the disease run its course. We don't always know the cause of it. It's just, why are you getting endolymphatic hydrops? I don't know. People don't always have a good grip on that. We don't always know. It's just going to happen. It's one of these Meniere's disease, not a pleasant disease to have at all. Now let's finish. Let's go to our notes here and see where we are. Let's see if there's anything about the cause of Meniere's. See that? You can read it. Caused by endolymphatic hydrops. But why? We don't always know. Excess pressure causes hearing loss and ringing in the ear. More pressure causes vestibular system to become overstimulated with resultant vertigo. And just have a read for yourselves. We are now getting toward the end of this particular unit. Head trauma can cause hearing loss. Tympanic membrane or middle ear may be damaged as well. If the fracture crosses the cochlea, however, the fluids of the cochlea will leak out and you're totally deaf in that ear. Acoustic trauma, diving accidents may cause round or oval window fistula, a hole in the round or oval window. Out goes the fluid, down goes the ear. permanent, gone. Paralymph fluid might leak into the middle ear. You'll likely lose your hearing in that ear. Head trauma. Now, cochlear dead regions is an interesting thing. Let's just, instead of reading this, let's look at our PowerPoint here to help describe it. Okay? When you're looking at cochlear dead regions, you can look at this area of the cochlea, totally dead. This area is living. This is a picture of eighth nerve fibers coming from the inner hair cells, and all of a sudden you've got totally dead area. Now remember the shape of the traveling wave from anatomy. Always remember this. This is very important in internalizing and understanding cochlear dead regions. Okay, a low frequency traveling wave stimulating apical low frequency cells. The dotted lines show the shape of a kite. You can see that the envelope is asymmetrical, steep front facing the apex, longer shallow sloping toward the base of the cochlea. And you can see that the outer hair cells are doing the sharpening. They amplify the peak and they also sharpen the peak. Now in the blue, you're looking at a high frequency traveling wave. It too is shaped like a kite. Shallower base, steeper front, and outer hair cells sharpening the peak as well over here. But we said that if you make the loud, low, or if it's a high frequency sound is rather soft, the rumbling of a truck outside is going to mask the peeping of the soft canary in the kitchen. Okay, because the envelope of the traveling wave will involve the soft high frequency sound, but it doesn't work the other way around. Okay, a high frequency sound cannot mask or cover a soft low frequency sound. So in red now you're looking at a soft low frequency sound, and in blue you're looking at a loud high frequency sound. And this wave is not moving out here. It's not involving any of this. And that is why lows mask highs better than highs mask lows. But keep the asymmetrical shape of the traveling wave in mind in order to understand that. These two pictures, very important. Okay, now let's look at a reverse hearing loss, kind of like Meniere's. Pretend this person isn't complaining of Meniere's, okay? He doesn't have any vertigo, no roaring tinnitus, but has low frequency hearing loss. And pretend the hearing loss is sensory neural, not conductive, okay? Now, watch what happens. Pretend that all the hair cells below 1,000 hertz, look at 1,000 hertz here, if they were all dead. So let me stop sharing screen for a second. Pretend that someone came into your room at night, put you out with chloroform, and went into your right ear and killed off every low frequency hair cell that represents sounds below 1,000 hertz. Left the ones above 1,000 hertz just fine. But the ones below 1,000 hertz, they were all killed. Now watch what happens here. Say that were the case. You would think that the person's thresholds would be at the bottom. You would think that the thresholds here, this would be down at the bottom, and 500 hertz would be at the bottom, and 250 would be at the bottom, and 125 would be at the bottom. Like all the O's would be at the bottom, and then suddenly normal. But that wouldn't be the case, and you know why? Because of the shape of the traveling waves. Look at the asymmetrical shape of the kites. Here's a traveling wave in the low frequency dead region. Let's call that a low frequency dead region. All the hearing is gone below 1,000 hertz, okay? You would think that the thresholds would be at 120 up to 1,000 hertz and then suddenly normal. Nope, the audiogram would look like this because of the shape of the traveling wave. Watch. If I'm presenting a 250 hertz tone, by the time I'm making it 50 dB, my traveling wave inside the cochlea is looking right where my cursor is, but look where the tail is. It's involving living hair cells. Guess what? You're going to raise your hand. You are hearing 250 hertz with remote hair cells, which is weird. Okay, you're hearing a 250 hertz tone, but not with the 250 hertz hair cells, because those are gone. But because you've made the peak of the traveling wave larger in that area, but the hair cells are dead there, the tail of the wave over here is still stimulating healthy mid-frequency hair cells. So you can raise your hand. You're hearing 250 hertz with off-frequency hair cells. Really weird. Cochlear dead regions. Okay, so it's going to look like you have a mild reverse hearing loss, a mild rising hearing loss. So what this loss could be real, or it could be because all the hair cells are dead and you don't really know. You know how the best thing you can do is ask the person what this tone sounds like. Does it sound like a nice hum, like a low frequency tone? Or does it sound or feel like a scratch or a tickle? Is it weird? And if it's weird, then don't try to amplify this with a hearing aid. Because you know what? Background noise is mostly low frequency anyway, and the hearing aid is just going to pick up background noise. Leave it alone. So this loss could be Meniere's, but you've ruled that out with the case history. No one's complained about symptoms like Meniere's, so forget that. And look at here, if I present 500 hertz, by the time I make it this intensity, yeah, the tail of the wave is still stimulating mid-frequency hair cells. The guy's going to raise his hand. All right, so you can see that these thresholds here, in this case, in case of cochlear dead region in the low frequencies, these thresholds aren't real. They're an artifact. Okay? Look at high frequency dead regions. Let's say, and I'll stop sharing now to give you the example. Let's say someone came into your room at night and put you out with chloroform and killed off every hair cell representing above 1,000 hertz. Left the low frequency hair cells alone. Just left them alone, but killed off all the high frequencies above 1,000 hertz. You'd have a high frequency dead region. And if that were the case, your hearing loss would go down, 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 down. Okay, I'll wait for this. There you go. Your hearing loss would go all the way down to the bottom of the page. More consistent with what you'd think. Okay, this is more consistent with what you'd think would happen. But why is this more consistent than what you'd think would happen with this? Okay, this, you'd think the low frequencies would be completely dead, but look at that. They're totally, it looks like a mild loss, but that mild loss isn't real. If this was a totally dead area, you'd get this audiogram because of the shape of the waves. Here, if I killed off every high frequency hair cell, the audiogram would look more like what you would expect. And again, the reason is because of the shape of the traveling wave. Look what happens when I present 1,000 hertz here. Make it loud enough, the front of the wave stimulates these living hair cells. 1,500 hertz, I've got to make it quite a bit louder for the front of the wave to still stimulate these living hair cells. If I go further into the heart of a Texas Saturday night, further into the dead region, I've really got to crank up the volume so that the front of the wave still stimulates these living mid-frequency hair cells. Do you see what I mean? That's why the losses drop dramatically in the highs. More with what you'd think would happen, but it's because of the shape of the traveling waves. Okay, so a high frequency dead region will look like a high frequency precipitous severe hearing loss. But in any case, are you going to focus amplification over here? No, the cells are dead. I would confine amplification with a hearing aid to this where I'm drawing here. You can help the dying, but you can't help the dead. Okay, so you focus more on the transition, but you'll learn more about that in future courses. I'm just giving you kind of a heads up here. Now here's what they call a cookie bite audiogram. A cookie bite audiogram looks like someone took a bite out of the middle of the cookie. Genetic and origin, fairly rare, okay, but you do find these. Could be because of the cochlear dead region in the middle, for the combination of the two examples that I showed earlier, but who knows? But fairly rare, but these are genetic in origin hearing losses. Here's a left corner audiogram. Now this person has hearing loss in the low frequencies, but has no hearing in the high frequencies at all. Okay, obviously both inner and outer hair cell loss. This could be a genetic hearing loss. You never know, could be, okay? They call that a left corner audiogram. So remember that shape too. It's important. When you see someone, when audiologists or HIS is talking about a left corner audiogram, it means basically the guy's got only a little bit of hearing and it's in the very low frequencies. That's all the person's going to be hearing. Some hearing aids today use what they call frequency transposition. They try and shift the highs and bring them to the lows so that the letter s, high frequency is brought more toward the low frequencies. But you'll study that too, again, later on in the course or in other courses. Okay, now let's finish today. So let's go to here in our notes. So now you can look at the cochlear dead regions thing that we talked about here. Total deafness in the lows can masquerade as a moderate, severe, or moderate reverse hearing loss, again, due to the shape of the wave. I've actually verbalized all of this, but this is it for you in writing. Total deafness in the highs can masquerade as a steep, sloping, severe, profound loss, again, more like what you'd expect. Again, for the reasons that we described earlier in your PowerPoint slides. And let's finish now with a word about otoacoustic emissions. OAEs, a non-behavioral test of outer hair cell function. Acoustic reflexes you can think of as a non-behavioral test. And what part of the cochlea is it involving? The inner hair cells. OAEs are a non-behavioral test that looks at the outer hair cells. And remember, non-behavioral means no voluntary response on your part. The action is acoustic reflexes. They kick in whether you'd want them to or not, non-behavioral. OAEs are actually sounds coming out of the ear. Never confuse them with ringing in the ear tinnitus. Okay, tinnitus is subjective. Only the person hears it. OAEs are objective. Outer hair cells increase the traveling wave height, amplitude, and they sharpen here. And that does not come without a cost. Okay? Work creates sweat. Sweat is the byproduct of work. Heat is the byproduct of a light bulb. Okay? The ear is no exception because the outer hair cells are sharpening the peaks of the traveling waves. You're going to have otoacoustic emissions. Moving down here, let's see our slide. We may very well have it. There we go. This work that you're seeing here causes otoacoustic emissions. All right, OAEs, always remember them as a non-behavioral test of the outer hair cells. If the outer hair cells weren't doing their job, there would be no sweat. And what is the sweat in this case? It's actually a backward going traveling wave that hits the oval window, wiggles the malleus incus and stapes, and now the eardrum is acting like a speaker. Now, thank goodness they're really soft. You can't hear them, neither can I. And let's look at why that is the case. If we share screen and go to our PowerPoint slide, And I'll wait for this ridiculous bar to go down. I can't stand that. There, go away. Okay. And we'll move down here, way down. We're at the end of our PowerPoint here. Okay, here we go. So remember the outer hair cells doing their work like crazy. Notice how the stereocilia are embedded into the underside of that tectorial membrane. When these cells shrink, they pull this tectorial membrane down so that these hairs can get bent. Remember, the outer hair cells help the inner hair cells pick up sounds below 50 or 60. The inner hair cells by themselves can't pick up 10, 20, 30. They need the outer hair cells to do this. So that's what the outer hair cells do, okay? And they create otoacoustic emissions. And now remember we said that when sound comes in, follow my cursor, hits a big area, and that force gets converged onto a smaller area, you've increased the pressure. Remember we've said that when you put your hand against your hand and push, there's not much pressure. But if you take your finger and push, way more pressure. Okay, if I push really hard, you'll see a dot. Okay, and that's the purpose of your middle ear. But when you're going back out, you're hitting the foot plate of the stapes, and that force is being dispersed over a bigger area, and therefore you lose the sound pressure. And that is why you don't hear otoacoustic emissions, thank God. Okay, going in you increase the pressure, but going out you don't. So otoacoustic emissions are actually, and this is called DPOAEs, distortion product otoacoustic emissions. And what they do here is they put in two tones. Look at the speaker 1 and speaker 2. And it's a little probe, just like tympanometry. It's a probe stuck in the ear. Doesn't have to be airtight though. But you'll have two speakers and one mic. So the speaker 1 and speaker 2 are putting two tones in the ear canal, and they have to be separate by a certain ratio. Okay, if one is 1,000 hertz, the other one's got to be 1,220 hertz. Don't ask me why, that's just the way it is. If one tone is 2,000 hertz, the other one's got to be 2,440 hertz. They need to be separated by a certain ratio. Anyway, they go in the ear canal, they go through the middle ear, they get to the cochlea, and the outer hair cells produce a different tone. And that's the otoacoustic emission in yellow. And it goes back out through the middle ear, back out into the ear canal, and gets picked up by the mic. DPOAEs. Here's a picture of it again. The probe in the ear, two tones, F1 and F2, separated by that particular ratio, and the distortion product otoacoustic emission coming back out only occurs if you've got healthy outer hair cells. Here's the two tones being put in the ear, a spectrum, and you have a couple of, here's the noise floor in the ear canal. You may have an otoacoustic emission here, but the otoacoustic emission in this particular case tends to be larger, so this is generally the one they focus on. And you don't normally do this. Audiologists sometimes do it, okay? Physicians sometimes do it. They test infants. When infants are born at a hospital, OAEs are one test that's done on the infant to screen for normal hearing or not. You see if the baby's got normal otoacoustic emissions. Now remember, if the baby's got an ear infection and the middle ear is blocked, well, if the middle ear is blocked, you're going to block the sound coming out. So if you've got a conductive hearing loss, you won't get otoacoustic emissions either, but not because you have no outer hair cells. You'll have no OAEs because of the blockage in the middle ear. So you can see how things have to be cross-examined. You can't just rely on one test, but just wanted you to know what otoacoustic emissions are and what they are used for and what they come from. Here's a person, here's the noise floor in an ear canal. And here they're showing the person had otoacoustic emissions, otoacoustic emissions, otoacoustic emissions, and all of a sudden, thunk, none. Here's F1 and F2 being put in the ear, and here's the otoacoustic emission. So this might be the case for all the different pairs of tones that are put in the ear across the frequencies. But when you got to this area here, where there were no otoacoustic emissions, notice that when the two tones were put in the ear, there was no otoacoustic emission. This is just a spectrum showing you the two pairs of tones, with a pair of tones put in the ear in the healthy hair cell region with an otoacoustic emission coming out. And this, what I'm circling, might take place for a pair of tones here, a pair of tones here, a pair of tones here, and so on, until you got to where there an area where there was no OAEs, and now the pair of tones are put into the ear, but there is no corresponding OAE coming out. That's the end of the PowerPoint presentation. We're nearing the end of our Zoom session. So basically, have a read of this, essentially, because it describes verbally exactly what we covered today. If you look at the vestibular system, and we're almost done here, because this is the end of the notes. The main disorder of the vestibular system is this. Benign, meaning it's not cancer, not malignant. Paroxysmal, remember that word from Meniere's disease? Means episodic. Benign, paroxysmal vertigo. Benign, episodic means it comes on, rotary, spinning around. What is that? BPV, put a star by it. Okay, that's all I'm going to say about it. You can read this here. It occurs when the tiny little stones that sit on top of the gelatin inside the ampullae of the semicircular canals. You have the semicircular canals ending in these little balls, little bulges. So the semicircular canal ends with a little ball on the end. Okay, remember you got 3 semicircular canals. And inside the little bulge, the ampulla at the end of the semicircular canals, look at your anatomy and recall this from anatomy. The hair cells are covered by a layer of gelatin. So you got the hair cells all standing up like this, and they're covered by a layer of gelatin. And on top of the gelatin are these tiny stones, so that when you turn your head or whatever, there's a lag of action because there's a bit of weight on top. If those little stones fall off, you don't have that lagging action, the normal thing. And so what you get, you'll get people complaining, yeah, whenever I move my head in a certain way, when I'm trying to tie my shoe and it's, whoa, I get dizzy. Or every time I bend over to pick up the weeds in the garden, if I turn to my left a little bit, whoa, do I ever get dizzy? BPV, benign, paroxysmal means it comes on, spinning. Okay, it's the most common cause of vestibular problems. It is the most one. Okay, remember what they do as a test for electronystagmography, ENG. They do a test for vestibular function. Remember that vestibular system is one of 3 areas of balance: vision, vestibular system, proprioception, knowledge of where your limbs are in space without you looking. Remember that from anatomy? Good. Benign paroxysmal vertigo means the stones have fallen off the gelatin, and what they do to fix this is they try to turn your head, and they do all these positional things to get the stones to fall back where they belong. That's a treatment. Head positioning. ENTs do it, some chiropractors do it, some audiologists do that. The HIS never does that. The HIS fits people with hearing aids. But you need to know of the existence of benign paroxysmal vertigo. You need to know that the test done for it is electronystagmography, ENG, and that the most common vestibular disorder is called benign paroxysmal vertigo, BPV. We are at the end of our Zoom session. We're done. We've covered pathologies of the inner ear. Next week will be session number 6. We're almost near the end of your summer course. We're looking at, you can see the light at the end of the tunnel. Next week, we cover retrocochlear pathology, pathology of the 8th cranial nerve. Be sure to have your PowerPoint or your notes especially printed up ahead of time for that Zoom session. As for this Zoom session, I'd highly encourage watching it twice. Always watch a movie twice. All right, I will stop recording now.